before you do that?
No, welcome everybody. The
Okay.
recording started.
Okay.
Yeah, so we welcome Dr. Gold. This is a topic that so many people have been really wanting to hear more about in the latest updates. And thinking about it, we think about Hopkins neurology, and Dr. Gold actually gave a recent presentation that one of our colleagues here, Ali Caro, had seen, thought it was excellent, and so we wanted to reach out. We're really fortunate to get this time period. Dr. Gold, who's a professor of neurology at Hopkins. Please take it away.
Okay, great. And thanks so much for the invitation. And let me share my screen here. So let me make sure, optimize. Do I need to turn this back on? Yes, apparently I do. Okay. So hopefully my videos will play and will not be psychotic. Let me get this out of the way. So I was asked to talk about sort of the emergent evaluation of dizziness and throw in some sort of video oculography, kind of what do we do here? What are some ways that could help us better evaluate these patients? And so we have a service called Teledizzy. It's not going to be all about Teledizzy. I suspect that the vast majority, if not all of you, are doing some virtual component, whether that's BAT calls, stroke calls virtually. So what can we do in person? What can we do virtually when we're assessing for possible stroke in this patient population? All right, so I don't have any disclosures, and actually I have my mouse in my bag here. There's a little bit of a lag here. Let's see if this works better. All right, so there was a lag and then it jumped ahead a bunch of slides. So I'm going to talk about our Teledizzy, kind of what we're doing with video oculography in the emergency departments. And we're going to talk about hints. We're going to talk about the Hallpike exams, which are really kind of the cornerstone of the emergent dizzy evaluation, and some pearls and pitfalls associated with the virtual evaluation of these patients in the absence of video oculography. So part one, we're in the emergency department. How can we leverage some of the tools that we have, the HINTS exam, video oculography? That's what we're going to talk about. And we're going to talk about it through kind of two patients here. There's a constant, these requests keep popping up. I guess I'll just continue to ignore them. So patient number one who has the acute vestibular syndrome. Is it possible to move this window out of the way? I guess I can't. Okay. So patient number one has the acute vestibular syndrome. What is the acute vestibular syndrome? It's the acute onset of continuous vertigo, nausea, vomiting, nystagmus, imbalanced head motion intolerance. If you're looking at a patient and they have spontaneous jumping of the eyes, nystagmus, this is not BPPV, right? This is the acute vestibular syndrome. 80% of the time you're dealing with something benign, although the patient is not going to feel like it's a benign problem at that moment. Vestibular neuritis, inflammation of the H cranial nerve, and about 20% of the time it's going to be something central, especially the vast majority of the time stroke. Could be a demyelinating lesion, could be Wernicke's encephalopathy, but generally speaking, we're talking about vascular event. And so how do you diagnose a patient with the acute vestibular syndrome? We're talking about the acute vestibular syndrome. We're not talking about other situations. We're not talking about BPPV. That patient with the acute vestibular syndrome comes in, you should be using the HINTS exam. The HINTS exam works beautifully in that patient population. And for you to be confident that you're dealing with a peripheral HINTS, vestibular neuritis, you have to have an abnormal head and pulse test. And here you can see an abnormal catch-up to the right side, meaning that there's a right hypofunction. And you have to have unidirectional nystagmus. And if there's a right vestibulopathy, you have to see left beating nystagmus. If you see left beating nystagmus, you have to see an abnormal catch up to the right side, an abnormal head impulse to the right. And you have to have a normal test of skew. There's no such thing as a horizontal skew. Our fellow a couple years ago is just doing an alternate cover here, and you can see a little horizontal correction. But horizontal correction, again, there's no such thing as a horizontal skew. You're looking for a vertical correction. These patients, assuming that they can see with both of their eyes relatively well, are going to be diplopic if they have an acute skew deviation. For you to be confident and comfortable that you're dealing with the peripheral Hintz exam, you have to have all of these. There are no exceptions, right? This is a 3-step test, not a 1-step test. And central Hintz exam could be a normal head impulse test. There should be spontaneous nystagmus present, right? You can't apply the head impulse test and use the rules of Hintz in a patient with BPPV. You might have upbeat nystagmus, as you can see here, vertical nystagmus. You might have bidirectional or gaze-evoked nystagmus, which you see here, right beating and right gaze. And there's going to be left beating and left gaze. That changes direction. That is a central sign. You might have an abnormal test of skew. And here you can clearly see that vertical movement, that vertical correction. So here, any of them, if you see any of them that's in a central pattern, you should be concerned that this is a central problem and not a peripheral problem. If it doesn't fit the peripheral pattern, it's central, simply put, right? If you can't convince yourself that those 3 peripheral patterns are present, then it's central until proven otherwise. Patient number 2 has positional vertigo. This is very common in the emergency department. Horizontal canal BPPV is probably just as common in the emergency department as posterior canal BPPV. These patients are very symptomatic and they come into the emergency department. I'm here to tell you that the Hintz exam and Dix-Hallpike work wonderfully if the exam maneuvers are applied appropriately. Hintz in the acute vestibular syndrome, Hallpike in BPPV, and properly performed. And the results are interpreted correctly. This is a peripheral Hintz. This is right posterior canal BPPV. And I'm not just making this up. There's lots of evidence, really robust evidence out there that this is what we should be doing in these patient populations. This is the GRACE 3, the guidelines that came out in the Academic Emergency Medicine Society publication a couple years ago. And these are the definitive recommendations, including from one of my mentors, who a lot of the Hintz, he's the Hintz guy, Dr. David Newman-Toker. In patients with nystagmus, trained clinicians should use Hintz testing to distinguish central from peripheral with a high certainty of evidence. That being said, what is a trained clinician? That's a little bit nebulous, and as of today, we don't have we have not disseminated Hintz training programs, which is something that we're interested in doing. Use the Dix-Hallpike test to diagnose posterior canal BPPV with a moderate certainty of evidence. But what happens with this exam, the Hintz exam, the Hallpike? Commonly, exam maneuvers are applied inappropriately. The Hintz exam is applied in a patient with positional vertigo who has BPPV, or the Hallpike is performed in a patient with the acute vestibular syndrome. What's that going to do? It's going to make them feel way worse. If you do a Hallpike on a patient who has vestibular neuritis or a vestibular stroke, they might throw up on your shoes, but that is not a positive Dix-Hallpike maneuver. That does not mean that they have BPPV. Or it's improperly performed. The head impulse test takes some time to acquire that psychomotor skill. And some people, if they haven't been given feedback on how they're doing it and how they're interpreting it, might not be doing a great job. I've been guilty of this previously, hopefully not in the last 10 years or so. And again, the misinterpretation. This is a peripheral Hintz when in fact the patient is having a stroke. So there are caveats to this. Is there a way, because we know that the Hintz exam works so well, that the Hallpike works so well, is there a way to cut down on the errors? And what we've been doing is a teledizzy consultation service where essentially these patients are getting Hintz exam, Hall Pike, with video oculography so that we can see the recording of the eye. We can see the patient and their position. And this is a left-ix Hall Pike maneuver. And you can see that there's a latency, and then there's an upbeat torsional nystagmus. Top pulls towards the left lowermost affected ear. This can be absolutely nothing other than left posterior canal BPPV, and we can make this diagnosis remotely and within a couple of seconds. The equipment is portable enough in 2026 as well, and it takes some of those sort of pitfalls of the Hintz and Hall Pike out of the equation. Exam is properly performed and recorded with expert interpretation. So what is the workflow that we've been doing? The dizzy patient comes in, obviously the lowest hanging fruit, the medical causes and obvious strokes. We want nothing to do with holding up the potential administration of TPA for these patients. And so if they're in a window, if there's any possibility that we're dealing with a stroke, the stroke team is consulted first. Not uncommonly, we're consulted by the stroke team when it's found that they are not having a stroke. And essentially, our threshold for a consultation is that your suspicion for a central disorder is high enough that you would normally order imaging. What is that imaging? That imaging is almost always a CAT scan, which is almost always worthless in this patient population, unless the patient has headaches and focal findings and change in mental status, and you suspect that there's a large hemorrhage, for instance. But an MRI is going to be far better at visualizing the posterior fossa, especially in the acute setting. And so we need an operator, we need the goggles, we need the video oculography system, which is portable, and Hintz exam is being performed with fixation blocks, so the patient's in the dark. We know that removing fixation is going to accentuate vestibular nystagmus. There are provocative maneuvers that we throw in that give us more sort of diagnostic and localizing value, as well as a Hall Pike and a roll. Supine roll test is sort of the best test for detecting horizontal canal BPPV. A giant caveat, right? Somebody in the emergency department needs to have them sit, stand, walk, assess auditory function, and perform otoscopy. Goggles can't do everything, although the eyes, the eye exam, the oculomotor and vestibular exam in this patient population by itself almost always can make the diagnosis. And there's an asynchronous, sort of a dizzy questionnaire, the asynchronous review, plus or minus sort of synchronous teleconsult with a patient, and sort of throwing them into these three buckets. This is red light, central stroke, need to be admitted. Green light, this is BPPV, this is vestibular neuritis. If it's relatively mild and they're able to hydrate themselves and they're not profusely vomiting, then they can go home with vestibular neuritis. Or, you know what, I'm not sure, we don't need a scan today, but let's have them be seen expeditiously in vestibular clinic. So what does it look like? We can see, as opposed to the head impulse test, we can see the video head impulse test, and we can see lots of information here. We can see that there are corrective saccades to the right side. We can see that the gain is much lower, 0.49 on the right side, on the paretic hypoactive side versus the left side, which is normal. So in 2 seconds, we can say they've got a hypofunction, a unilateral hypofunction. And we see unidirectional nystagmus that we would expect to see. If there's a right hypofunction, the patient should have spontaneous left beating nystagmus. Almost always in the emergency department, it's going to be sort of mixed horizontal torsional nystagmus. It's going to stay left beating in all directions of gaze, even right gaze, as you can see here. And in accordance with Alexander's law, it's going to increase in the direction of the fast phase to the left. And we can also do a test of skew, where here the right eye is covered, the left eye is covered, the right eye is covered, the left eye is covered, and we're looking for any degrees, in degrees, any deflection, vertical correction, but we could also see it here. So we've now completed the three-step test and demonstrated with a very high degree of objective, quantifiable certainty that this is right vestibular neuritis. And so what are the challenges? Challenge one is that the testing is technique dependent, need to train, monitor, and maintain those skills. But the good news is that the software does give real-time feedback, too slow, overshoot, And again, my mentor, Dr. David Newman-Toker, has shown that novices can be trained up to perform at the level of an experienced neuro-otologist within hours. After a couple of hundred impulses, they can get to sort of an expert level pretty quickly, but that needs to be maintained, and that can be a challenge. Challenge number two, we're measuring the eyes. So not every patient's a good candidate. There are blinky patients, there are sleepy patients. I can't say much about anything in these two patients, and these are both patients who were in our emergency department. And the goggles only evaluate the eye movements, right? So the patient's asymptomatic. If they're asymptomatic, probably the oculomotor exam is not going to be so helpful. It's not going to be so revealing. So you got to risk stratify, ABCD2, et cetera, and I don't need to lecture this audience about that piece. But you can't rely on hints by itself when there's no spontaneous nystagmus. When the patient is asymptomatic, at that point, they're no longer in the midst of the acute vestibular syndrome. Hints works very well in the setting of the acute vestibular syndrome. And what about this, right? It's possible to have a cerebellar stroke with normal eye movements, but do they have truncal ataxia? Can they sit independently on the edge of the bed with their legs dangling and their arms crossed? Do they have gait ataxia? So the general neurologic exam, especially gait and stance, are especially important in the absence of spontaneous nystagmus, when the eyes don't give you the answer. And from the GRACE 3 guidelines, this is what we should be doing. In patients without nystagmus, assess the severity of gait unsteadiness to distinguish central from peripheral diagnoses. What about a patient with acute deafness? We know that the basilar artery supplies the anterior inferior cerebellar artery, which supplies the internal auditory artery. So you can have a labyrinthine stroke. But if you have a labyrinthine stroke, almost always there's going to be cochlear ischemia, in addition to sort of ischemia of the vestibular organs. So these patients can have a peripheral vestibulopathy with acute deafness on the same side. So what should we be doing? We should be assessing hearing by finger rub to distinguish central from peripheral. You got it. Somebody has to perform otoscopy as well. Is there pus? Is this bacterial labyrinthitis? Is this Ramsay-Hunt syndrome? So again, somebody, boots on the ground, somebody needs to evaluate not just the auditory function, but otoscopy as well. And this is the last slide on teledizzy, and then I'll talk about sort of the non-VOG related sort of virtual assessment. And so with teledizzy, compared to sort of a baseline rate of similar patients who presented outside of teledizzy hours, we've been able to establish many more specific vestibular diagnoses. This is right posterior canal BPPV. This is left vestibular neuritis, et cetera. And we've been diagnosing stroke more than the baseline rate. The non-diagnoses, that is symptom diagnoses of dizzy or vertigo when we don't have a clear explanation, have been cut in half. The CT or MRI has been cut in half, and that's mainly because we've drastically reduced the number of CAT scans being ordered, because it's just not that helpful in the vast majority of these patients. MRI rates have been about the same, and after 30 days, 0 stroke readmissions or stroke admissions in the next 30 days. So part 2, virtual evaluation. What if you don't have video oculography? What can you be doing? So number 1, if this patient's in the emergency department and you're doing a teleconsult, if this patient's at home, you can do, this is not so realistic that you're going to have 2 camera angles, but in a perfect world, you would know what the body is doing, you would know what the head is doing. But if you have a pretty good sense, sending them some diagrams of what this should look like, putting a pillow in the middle of the back so there's a little extension at the end as well. And this is a left Dix-Hallpike now, and if the patient can do something that approximates a left Dix-Hallpike and put the camera pretty close to their eyes, you can see if there's upbeat torsional nystagmus towards the lowermost left ear, that's BPPV, or maybe you see horizontal nystagmus, in which case you're going to say this is probably horizontal canal BPPV. You can now do the supine roll test. What is that? Now she moved the pillow from the middle of the back to under her head. Her head is flexed a couple degrees, and now she's just being asked to rotate, to roll 90 degrees to the right or 90 degrees to the left. This is the supine roll test. This is the better test for detecting horizontal canal BPPV. Sometimes you see posterior canal BPPV with this maneuver. Sometimes you see horizontal canal with Dix-Hallpike. So if you do a Dix-Hallpike and it's negative, or you see a little bit of horizontal nystagmus, I would definitely do this next. You might see a lot of horizontal nystagmus to tell you that this patient has horizontal canal BPPV. And these patients, their first attack of BPPV can be really debilitating. And the first thing that many of these patients think is, could I be having a stroke? And a lot of these patients, as I think everyone here knows, wind up in the emergency department. And this is highly effective. What about anything that's not BPPV? So it's really helpful to have patients send you home videos. And if the patient's in the midst of their ictus and you can evaluate at that time, and you know that a patient has hearing loss in one ear and has a long history of Meniere's and has had lots of these similar attacks, and today is in the midst of an attack, you might see a very robust horizontal nystagmus. Robust horizontal nystagmus is something that we see in Meniere's. However, if a patient presents with their first episode of vertigo and hearing loss, you should be very concerned about the possibility of labyrinthine ischemia. Or maybe a patient has a long and strong history of vestibular migraine, and they're having headaches and they're having vertigo, and you have a connect with them via FaceTime or have them send a video and they have much milder horizontal nystagmus. Or they have vertical nystagmus. Vertical nystagmus, upbeat or downbeat, can be seen in vestibular migraine, but I would be very concerned, very hesitant to make the diagnosis of vestibular migraine without that long and strong history, especially if you're seeing vertical nystagmus. If the patient has dizziness and new headaches or severe sudden onset or related to injury, be very concerned about the possibility of vertebral artery dissection. Do not make the diagnosis of vestibular migraine at that point. And TIA, this is a patient and he has very extremely mild nystagmus, but he's diplopic over here and there's a tiny little abduction deficit. It's really subtle, but a video allows you to slow it down and take screenshots and look at it. And he was having episodes of vertigo and horizontal diplopia, worse to the left. And he had very severe disease involving the left anterior inferior cerebellar artery. And he was having TIAs that were affecting the lateral pons, causing vertigo and a 6-nerve palsy, which we could see on that home video that he sent. So what can you do? Again, the patient's in the emergency department, you're not there, you don't have fancy equipment. Removing fixation works really well. Removing fixation is going to accentuate vestibular nystagmus. How can you do that? You can do that with the pen light cover test. Occlude one eye and have somebody shine a bright light in the opposite eye. If the patient's having vestibular neuritis or a vestibular nystagmus, oftentimes this partial removal of fixation will accentuate the nystagmus, make it much easier for you to see. You could have the patient look right, left, up, down, and you can make a determination. You could also throw in different provocative maneuvers. If you see a central pattern of head shaking, patient has right beating and they shake their head and now it's left beating. That's a central pattern. Patient has nystagmus or no nystagmus and you shake the head horizontally and they have vertical nystagmus. That's a central pattern. So there are very well-known central and peripheral patterns. If you do this, make sure that this is the last thing that you do because the patients won't like you. And if they're acutely vertiginous and you shake their head around a lot, they're going to feel much worse. So do this last if you do it. Hyperventilation is not so helpful in the acute setting, but another provocative maneuver, Valsalva. Hyperventilation can be good for things like vestibular schwannoma, vestibular paroxysmia. Valsalva can be good for things like superior canal dehiscence syndrome. Vibration is another nice provocative maneuver to increase vestibular asymmetry when there is any that's present at baseline to bring it out. But the head impulse test portion of the hints doesn't work well in the acute vestibular syndrome. You can look and see that if they have nystagmus and whether it's unidirectional or bidirectional, but the head impulse is tough. What is that impulse? This is a patient with bilaterally positive or abnormal head impulse. And what happens? You move the head to the right and to the left, and you see these catch-up saccades. That tells you that there's vestibular hypofunction. This is a patient who I'm just saying, please start out to the side and try to wind up in the middle as quickly as you can, sort of playing a game. How fast can you get the head back to center and look at the camera? And the point is that because this is controlled by the patient, it's predictable. And even if they have pretty severe vestibular loss, you might not be able to see it. And I'll show an example of that in a moment. If you're evaluating a patient virtually with the HINTS exam, the test of skew works well, right? Whether that's with VOG, whether that's without VOG, whether that's the patient's at home, you can just simply have them use their fingers, their hand, although oftentimes they're going to do this and not do a good job. So their phone works well, a spoon works well, right? Anything that looks like an occluder. This is a patient who I know has severe, really profound vestibular loss bilaterally. And so I asked him to do this from his home. Move your head as quickly as you can back to center. And you could see a little catch up there. You could see it. But this patient has really, really profound vestibular loss. So if somebody has mild vestibular loss, if somebody has you might not see it. You could see it because they haven't had a chance to compensate yet, right? If it's acute, if it's in the first couple hours, the first day or two. So you could try this, and if you see an abnormality to the side that you would expect, then that's great, and you could be much more confident that you are dealing with a peripheral vestibulopathy. You see right beating nystagmus, you have to have an abnormal head and pulse test to the left, toward the side of the slow phase. And so lessons learned in the emergency department with teledizzy, greater diagnostic accuracy using a VOG enhanced HINTS and Hallpike, lower utilization, less radiation with CTs, and when imaging is necessary, we've been using MRI. Lots of barriers, training, billing, funding has been the biggest issue as of late. Staffing, right? These patients come to emergency departments 24/7, so that can be a challenge. Lessons learned in the virtual clinic. So history is important, even more so in the virtual world. But if you're able to add a focused exam, you can get a lot of information, and you can easily see if it's a central pattern of HINTS, if it's a central pattern of nystagmus, if they have a skew, and you're done. But it's a little harder to fulfill the three sort of peripheral, more reassuring signs to suggest the vestibular neuritis. And next steps, so leveraging app-based technology. So the not too distant future, maybe there's a teledizzy portable in the emergency department, but there's a teledizzy mobile, right? And phones these days, smartphones these days, the cameras are really, really good. So colleagues in our division with Dr. David Newman-Toker and Ali Tirani and Jorge Otero Milan have been working on software that essentially does a pretty good job of approximating what the $40,000 video oculography goggles can do. And so what we're trying to do is to put this technology into the home, into potentially the EMS, right, services, into the ambulance, on the way to the hospital, into the emergency department, so that we can cover more ground, and one expert can cover multiple hospitals, for instance. Trying to refine sort of AI algorithms so that the lowest hanging fruit can be eliminated. This is right posterior canal BPPV. This is a stroke. And then the expert evaluates the other video oculography traces that are a little bit less clear, and sort of establishing some sort of a pathway where they need some additional evaluation. They don't need to go to the hospital today, but how can we evaluate these patients urgently? So that is 29 minutes. So if anybody's interested in these videos much more, feel free to visit. The North American Neuro-Ophthalmology Society has a neuro-ophthalmology virtual education library, and I have my own eye movement vestibular collection there. I also have written a book on neuro-ophthalmology and neuro-otology. I'm not trying to sell it to you, although by all means, feel free to purchase it. But all of the videos and a lot of the electronic content is available in my collection for free. So thank you for your time and attention.
Dr. Gold, do you think you have time for one question?
Yep, absolutely.
I saw, so one from my colleague, Jennifer Winkler, who's chair of neurology at Baylor Scott and White, which has a very large neurology health system in Texas. She was just asking about apps. Are you working on apps?
Yeah, absolutely. So nothing is available to the masses as of today. There are some folks in Germany and elsewhere in the world. There are multiple groups working on apps. So some of these might be much more accessible in the near future. But as of today, there's nothing that you can download to help quantify nystagmus or the head impulse tests. But more to come, much more to come on that.
It could be well, maybe we'll encourage, because I know you're going to have to go, might encourage our colleagues in our network to watch your video, and then maybe we could invite you back for a question and answer session.
Sure, happy to help. I mean, if there's another burning question or two, I can answer it. Otherwise, I'm happy to do some Q&A at another time.
Anybody? Okay.
No burning questions.
Wonderful.
Okay. All right. Well, thank you for the
so
invitation.
much.
Thanks for your attention, and appreciate it.
Take care. Thanks so
Okay,
much.
bye.